Straight Islander people today. So it is my great pleasure to introduce our very first speaker of the day, is Dr. Noemi Fuentes-Bolanos. Dr. Fuentes is a pediatric oncologist who joined the Kids Cancer Center in 2018 as a postdoctoral clinical research fellow in cancer predisposition. Her research focuses on the analysis and interpretation of paired tumor germline genomic profiling in childhood cancer and the translation of these findings into a meaningful model of care as part of the Zero Precision Medicine program. Dr. Fuentes is involved in the development of a number of national clinical guidelines for the surveillance of children with cancer predisposition syndromes, and she coordinates the PREDICT study, which is a statewide pilot study analyzing trio-based whole genome sequencing in every newly diagnosed child and adolescent and young adults with cancer. Dr. Fuentes has completed international fellowships in pediatric oncology in Spain, the UK, and Australia. She has a master's degree in biomedicine and a PhD in epidemiology. She has also further subspecialized in cancer genetics. So very excited to hear her talk today on genomics translation, the cancer genetics flagship.
Thank you. Thank you to the organizers for inviting me to do this talk and for the introduction. Well, genomic scientific advances has actually overcome currently the ability of health systems to anticipate the ideal conditions and therefore the processes and systems that we need to have in place. It seems like the translation to research findings is a continuous ad hoc exercise, but actually genomic translation is much more effective when it's developed by what we call a flagship. Flagships are multidisciplinary clinical groups with those with local expertise and knowledge, who are actually able to develop or influence the development of these processes. I'm going to talk to you today through our experience in genomic translation in pediatric cancer genetics in Australia through the two big projects that we are involved, PREDICT study and through Zero. Starting by PREDICT study, this is a New South Wales-based multi-center study that aimed to sort of analyze the genetic genome for germline testing of patients that are diagnosed with a cancer within the 60 days from the diagnosis. And we aim to collect whole genome sequencing data from both parents and the patient. And actually why we thought initially there was a good initiative. Well, actually, because a recurrent question that we have in clinic in our patients when you tell the families they have a cancer was, why my child has a cancer? What is the reason that why my kid and not a different kid? So then there is a big group of people, and actually our flagship in New South Wales, which is built by two different components, which is the clinical side, which is the Kids Cancer Genetic Clinical Team, which is embedded and built on the Kids Cancer Center here at Sydney Kids, and the Genomic Childhood Cancer Risk Team, which is led by Mark Pines, and it's actually part of the Children's Cancer Institute. Some of the components of the teams are actually in both teams, for example, ELISA. We also collaborate very closely with people that are interested in the same theme or the same field in Westmead Hospital, which is, for example, Bhavna, who is a pediatric oncologist, or Diane, who is a molecular scientist. So then through this collaboration, we actually were able to identify not only research questions that we can answer through PREDICT, but also translational questions. For example, when we expose this or we should share this idea with our colleagues, they will say, well, is that actually a safe time within 60 days from diagnosis? And not the patients are going to be too stressed and the family too stressed to have this test offered? Well, actually, that could be one of the questions we can answer. And that's purely addressing a question in translation. But then also there are other more complex germline research questions that we are able also to sort of at least elucidate or help or contribute to find an answer, such as, are there any relevant findings in part of the genome that we usually don't read or are hard to read, and how useful they could be in the clinical setting? If you see, we now have enrolled more than 200 participants in this study, and we actually developed this flow map in which we ensure that we enable genomic research, but in a clinical reporting context, in a research that actually report results to the patients, to the clinicians and the patients. We came together with this flow map in which we have on the clinic on the left-hand side, the clinical domain, which will integrate the available data, the clinical information, define the genes that actually are clinically actionable, curate the variants and report the findings together in conjunction in collaboration within these researchers, so molecular curators and the clinical team, and we report these results to the clinicians. Then on the right-hand side, there is the research pipeline, which is the research domain. This part is usually the information that we discuss all the time is the identify, and we put the clinical information together, but we are a little bit more broad in the analysis that we performed. And we review research findings that are not necessarily translatable to the clinical side. However, if there is anything that we identify that could potentially be reportable or could have potentially clinical implications, then those variants or those results are discussed with the clinical scientist part of the team, plus the whole multidisciplinary team part of the research study, and then we assess if it's necessary to report it to the clinician or not. But overall, the findings identified through the research domain are not reported to the families because they are assumed to be not directly clinically actionable in the current states of the knowledge. Through this process, we actually found that it was a practical, flexible way that ensured enough flexibility between the two domains of the study. And actually by implementing this and sort of closing a little bit the collaborations between the research and the clinical part of the study, we learned many lessons that actually has directly impacted the design of 02, which is a national clinical trial. Let's talk about 02. So 0 is a childhood cancer program. It's a national pediatric precision oncology program. And it's actually a joint initiative between Children's Cancer Institute at Kid Cancer Center at Sydney Kids. It also includes 9 sites in Australia and 2 sites in New Zealand, in which they are clinicians and teams who see on a regular basis children with oncology conditions. This was initially started in 2015, and now we just launched this year the phase 2, which is offering molecular profiling to every child with a cancer in Australia. But this molecular profile, where it is a little bit. So the pipeline on this study, and I think this is important to understand the translational component of the study, it goes as I'm gonna take you through. The phase 1 is we collect samples from the child from the peripheral blood, or if peripheral blood is not a good alternative, then maybe skin biopsy or other germline biospecimens. We also take a sample from the tumor, and we extracted the DNA and the RNA. And this is just to put this information through our in-house bioinformatic pipeline in order to analyze the whole genome sequencing from the germline and the tumor sample, plus the RNA expression and methylation studies on the tumor sample. We have optimized our in-house analysis of the RNA expression through the expertise of Chelsea and the methylation studies through multiple teams involved in the Children's Cancer Institute, such as Fa and her team. With all of this information together, I want to introduce you to a very critical group of scientists within the program that are the clear example of the points where the research and the clinical side actually emerge. The genomic curators are a group of molecular scientists who have the ability and the knowledge to integrate all of the molecular information and the RNA expression and methylation studies, put them together with a little bit of the clinical background that we have about the patient, and then try to filter all of that data that has been filtered through the in-house bioinformatic pipeline, looking for findings that could potentially be clinically relevant. And by this, obviously, the concept is quite broad, but they have to select those findings that then need to have further discussion. And that's a really critical role in between what is research and what is actually clinically translationable. Then, obviously, they don't make these decisions in solo. Those selected findings will be discussed in what we call a curation MDT, or a curation multidisciplinary team meeting, in which the curators present the results and we discuss with many of our colleagues. And this will include everyone who needs to be involved in the discussion to understand the results and to assess the clinical translationability or actionability. These include the bioinformaticians who were involved in developing the in-house pipeline, the molecular oncologists who understand the findings, predominantly the implications to the treatment tumor or treatment behavior, the cancer genetics team who actually are able to integrate both information not just only from the GenBi, but also the meanings and the expected features on the tumor. And finally, other researchers. By other researchers, I will explain to you in a few slides what I mean, but I just thought it was important to highlight the multidisciplinary nature of these meetings. So then how all of this is translated into clinical practice. So this is a molecular profiling that is the results are discussed in this multidisciplinary curation team. Then there is a genomic curator who has been allocated to the case, and then there is a clinical scientist who has been allocated to the case as well. Both together prepare the case in order to ensure that facilitate the interpretation or the understanding of these results in a more national approach for those who may not be expert in genomics. If there is anything that is relevant from the germline point of view, or there is a cancer predisposition syndrome diagnosed, this team will be joined by a clinician scientist with expertise in cancer genetic risk. So either genetic curator plus clinician scientist, or in addition with a cancer risk clinician will prepare the case, and they present it in a national molecular tumor board. These meetings are every Tuesday, and the audience on the meetings are a mix in between clinicians, pediatric oncologists, cancer genetics, GCs, anatomopathologists, radiologists, surgeons. It's open because it's a platform to educate also on how to interpret these results and promote a discussion in which we enable a multidisciplinary discussion, including bioinformaticians, people coming from the research, people coming from the clinical. As a conclusion of all of this discussion, we issue a research report, and then it's expected that the treating clinician will discuss the results with the patient and then will communicate what is the decision or the recommendation or the action plan. This seems to be actually a quite sort of 1-to-1, 1-to-3 step, but we certainly have to accommodate flexibility in our models in which we have the research component. So for example, obviously in the discussions or in the National Molecular Tumor Board, there are sometimes questions that have not been addressed, or questions that are touching in between the research and the clinical that are really interesting or important to address, and we may have not realized that could be something that interests the clinical side of the study. What we do then is feed this back to the genomic curators, and the genomic curators actually have the possibility to feed this back to the molecular profiling pipeline. So we adjust and adapt to the new changes on the field. But there are other things that we are flexible to integrate. So for example, initially in 2015, when this was started, it also started the research projects in high throughput drug screening and patient-derived xenograft. These are preclinical studies in which initially there was not the expectation initially that we'll have a direct impact in treatment and clinical decisions. But actually, obviously, while the expertise within the research program was evolved and developed, and also at the same time that the literature and the research evolved in the understanding of these results, we were able to have results in a way that we can actually inform the case preparation and present results that may have impact on the patient's care. This was after, obviously, several steps in the pipeline and after a very thoughtful revision of how these results can be useful to influence clinical management decisions. And there are other research projects that are not yet included in our returning of the results or clinical translation component, such as liquid biopsy. So, for example, imagine a patient that has a cancer, and then that patient in particular, the biopsy is not safe because it's really risky and it could compromise, could put the patient in a life-threatening situation. In those cases, maybe a liquid biopsy, which is taking a sample from peripheral blood and look for cells that represent the cancer, may be an alternative. Obviously, this technology is not, from our point of view, at the point of substitute completely the current standard of care. So we don't use it to directly impacting clinical decisions. However, based on the need of this technology, we are working towards optimize and validate this type of technologies to be able to use it in the care of our patients in the future. What have we learned through this pipeline? Well, through the paired tumor and germline analysis that we were able to include in this program, we now know that 1 in 6 children with a high-risk cancer has a genetic cancer risk. And actually, up to almost 80% of the variants that we found through this study had a direct cancer surveillance or risk reduction implications for relatives, not just for the children that are involved. This is all directly clinically impactful in the patient and the patient's care. And also we know that around half of them, we have a genetic cancer risk that actually put the patient at a higher risk of cancer if they are exposed to chemotherapy. Certainly this unlikely will impact the decision of the oncologist to choose one chemotherapy or another, because obviously the cancer treatment, it's most of the time more critical. However, it adds information about the patient's risk and inform these families that are receiving this chemotherapy that maybe by giving the chemotherapy, we actually are increasing the risk of another cancer. And information and obviously communication is always important with our patients. But finally, and actually probably very interesting, half of the findings, 5 of the patients with a genetic cancer risk variant was diagnosed just because we applied the research pipeline that we were able to apply because it was in a research context. So we do strongly believe that these patients will not have been detected through standard clinical care. And this is because multiple reasons and because of the research pipeline allow us to be flexible in our approach, always based on the fact that it's in a responsible way. So as you can see, we have the New South Wales statewide flagship composed by researchers, clinical researchers, and clinicians. But actually, this study is a national-wide, and we are really proud to be able to say that we have been able to build a community of people who are experts on the field that are interested for different reasons in this particular topic, not just clinicians, geneticists, genetic counselors, but also researchers from the labs and from many different fields, put them all together in order to answer many questions. And this is what the clinical arm of the study has enabled to answer so many questions that we want to answer. I wouldn't take you through all of them, maybe just a few of them. For example, the questions comes from how the RNA actually help us to understand what we are seeing through Chelsea, or how actually the findings that we are seeing can help us to treat the cancer better. But also, for example, which model of care is the best fit for this type of families and this type of clinical practice. But obviously, as you all know, this intersection in between research and clinical is not exempt of challenges. And these challenges are around what we know as principles of complexity. Some of them, for example, it's described as a behaviors of the age of chaos. I like this because it represents very well what we sometimes feel, people who work in this field. You feel that you have multiple research hypotheses, as I just explained, complex research pipelines to make sure samples are collected and everything, embed in a very multidisciplinary team in nature, like there are many clinicians involved in making decisions in our patients, and they have to make very complex decisions. The level of knowledge that they need to have to make these decisions is really difficult to achieve. All of that together looks like a bit of a chaos, so we have to find our own sort of organization there. And this implies, because we are changing it very quickly, that we have to change the organization or the hierarchies very quickly, meaning that actually we have a lot of different individuals with a lot of different skills, with a lot of different backgrounds, a lot of different goals. We have to put them all together and keep reorganizing, because what now is the most important bit on the pipeline, next week can be less important because you have something else that you have to focus your resources on. And then finally, you have these random actions that you develop to address a specific problem in a specific patient. And actually that becomes something that can generate a pattern and can make the workflow work much better, or can help the acceptability of what you do, or reduce the cost, or just impact in the way the systems are built. So I'm going to give you an example of how we try to address this sort of chaos, but not chaos, and reorganizing and making sure that we are delivering thoughtful care to our patients. So imagine that a patient is identified as eligible for the research pipeline for 0, At the same time, it's referred to Cancer Genetic Clinic. How we actually put both pipelines together in a way that we don't add any extra steps for the families, but ensure that we are also generating research results that can help developing models of care that will benefit the patient. Well, so the clinician who see the patient in clinic for the diagnosis of the cancer, the oncologist, they will offer the zero study and consent for the study. And in parallel, obviously, the clinician who see the patient in cancer genetic will maybe decide the patient needs a genetic test and will consent for this the test. We are not taking blood twice, right? So we try to put the same time the collection of both the blood for the study and the blood for the clinical test, just to make sure we make it easier for our patients. Then what about the results? Sometimes the results about genetic conditions come from the research before we have results from the clinical pipeline. And sometimes it's the opposite. And that's one of the examples of these cows that I mentioned earlier, no? So what happens if you have, first of all, the results from the clinical or before the results of the research? So if you have the results, for example, from the research team knows that they have to inform not just the oncologist, but the cancer genetics team as well, to make sure that they are aware of that results are available. If we have results from the clinical testing before we have results from the research, we also feel that we have to communicate to those curators who spend a lot of time trying to understand things that maybe they can spend that time in a different thing that also could be very important. So the communication between both is very important. But who returned these results and how? That's another question. So we are lucky to say that through these flagships or through these multidisciplinary groups of experts, we are working towards how we can return results together in order that being cohesive and understandable for the family. So from the research point of view, we have the molecular tumor board. We discuss results there and we ensure that we have opinion from everyone together to see what is the best for the patient. From the clinical point of view, we have the clinical meeting. We meet every week at the Kids Cancer Genetic Clinic and discuss our patients, our results, those with synergies with the research results. Do we have them? Do we know what is the plan? So then we plan together to return results together. And then from the research point of view, there is a research component of the study that includes qualitative interviews of the families to check for their experience. If there is anything that is relevant, we apply to patient selection or the whole pipeline of the research to make sure that we are not doing anything that should be addressed immediately. Similar from the clinical side of view, we have a senior nurse coordinator who is also doing a PhD, models of care, who will help us to ensure that also we adjust or review anything that we are implementing on the clinical model of care that could be improved or needs to be improved. Then it's important, obviously, to keep the communication in between both sides. And I think that message has already come across through my talk. So I'm just going to take you through an example. Yep, and I finished. So I'm taking you through a more sort of example about something that we have experienced in PRISM or in Zero, and actually exemplify very well how these synergies or how this translation between genetics research and clinical work. So imagine Ella. She is diagnosed with a disease called A, and she started treatment for that disease. Then is enrolled in Zero because the oncologists believe that that can benefit her. So send tumor and germline sample to be analyzed. And actually, Zero germline results reveal that there is an underlying genetic condition that is highly suggestive of a completely different disease B. Then the clinical scientist who is involved in the curation of this case with the biocurator informed the treating clinician that actually the molecular results are suggestive to something different. Obviously, we don't advise to change literally the diagnosis because we are careful and aware that this is a research result. What we do is to support the anatomical pathologists in this particular case, what we did to review the pathology and see, look, is disease B possible at all? Are you confident with the diagnosis of disease A? Because the research results are suggesting something different. In this particular case, the anatomical pathologist revealed he was a bit unspecific features. He was not 100% confident. And then actually he realized that with disease B, which was a really rare disease, the anatomopathology features were completely in keeping. This changed the diagnosis of Ella to disease B, and therefore did really change the treatment, and actually would make us able to identify relatives at risk, because we were able to offer them tests. So this is the conclusion of how actually we sort of, in a practical way, in a case way, we address these core challenges of the translational phases. So the first will be the pre-adoption, case by case. With Ella case, we learned. With the need for liquid biopsy through the clinical experience, we learned. And that evolved into, okay, we're learning this is a need in a case by case. Maybe we should do this more systematically in 02. Then, as we did with in vivo and in vivo assays and the animal models, then we learn how we can translate this into impacting clinical decisions directly, so we make it more systematic. We adopt this sort of research approach in our program. And then actually the next phase will be how you implement this in a model of care, no? For example, how we have learned through our experience with the germline analysis on 02, things that can directly influence in the way Kids Cancer Genetic Clinic actually deliver their model of care. And finally, all of these obviously inform potential health systems, how these implementation measures are actually sustainable. So I just want to acknowledge and thank everyone who is involved. And you see, it's interesting, I have an acknowledgement slide from the Children's Cancer Institute, an acknowledgement slide for the Kids Cancer Genetic Clinic. And you will see that KCC has many people who are actually involved, which is revealing the translational measure of our Kids Cancer Center as a team. And any questions? So I'm very, thank you.
Thank you. Great talk and amazing work that you're doing with your team. I think we have time for one question. I just wanted to check if there's anyone. Are you able to see Sam in the Q&A? Okay, so I just have one question. Actually, with your experience with whole genomes, actually, anyone questions? No questions here? Okay, just one question then. With variants of unknown significance in whole genome germline sequencing, because I saw the great work, like 53% of diagnosis through research. How do you, like, I guess one of the major questions is, as the VUSs become non-VUS, is there a way that you're communicating that back to the families?
Yeah, so that's a really important and interesting question with a long answer. I will try to be succinct. So there is certainly some of the a small minority of those findings actually were variants of unknown significance that were close to enough to be likely pathogenic. In those cases, by integrating the information from the tumor profiling, maybe in cases where actually was consistent to the role of the germline variant in tumorigenesis, we were able to suggest a reclassification of the VUS. On another hand, to your question, if we have variants of unknown significance that are highly suggestive of their role, but not enough to be communicated to the clinical team, then we certainly review them in a yearly basis. And that's the last part of my answer, is where we learned and we advocate for returning variant of unknown significance to the clinical teams if they are relevant, and then support and upskill the teams who receive the results into communicate these results to the families in a responsible way. Thank you. Thank you.
Thanks again. Thank you. Great talk. Thanks so much. Just going to change the PowerPoint. All right. Thank you. Okay. Okay. And it's my pleasure to present our second and final speaker of the day, Professor Edwin Kirk AM. Professor Kirk is a clinical geneticist at Sydney Children's Hospital and a genetic pathologist at New South Wales Health Pathology's Randwick Genomics Laboratory. Among his many achievements and appointments, Professor Kirk is co-leader of a groundbreaking national reproductive genetic carrier screening study known as Mackenzie's Mission. His main research focuses on reproductive genetic carrier screening, and his other research interests include congenital heart disease and the causes of intellectual disability. Professor Kirk has also authored the popular science book, The Genes That Make Us, Human Stories from a Revolution in Medicine. So today, we look forward to him presenting on Mackenzie's mission.
Thanks very much for that kind introduction. My publisher informs me that based on sales, it's more of an unpopular science book. I know you're all mad tweeters out there. A lot of the stuff is still unpublished, although we do have a manuscript that we're about to resubmit to a popular magazine. Hopefully that will change shortly. This talk is much more about Mackenzie's mission and rather less about the way forward. So I hope that's all right, because I know this was meant to be about translation. The acknowledgement slide gets bigger and bigger. We had over 1,000 people who contributed in one way or another to the project, and obviously we can't fit them all on to this one slide. So why Mackenzie's mission? The background was that and the argument for accessible carrier screening had been building over a while. Really, from my point of view, as soon as exome sequencing started to be a thing, I was thinking about this because of having conversations with families about severe recessive conditions in their children and thinking about the possibility of doing something ahead of time about that. And so a group of us had approached the federal government to talk about the possibility of a pilot project. As it happened, Mackenzie Casella died aged 7 months from SMA in 2017. And her parents, one of the first questions they asked when they got the diagnosis, when she was a bit younger than that, asked why they hadn't had screening, and because they found out that it was possible. And they became these incredibly powerful advocates for carrier screening, and they lobbied the federal government very effectively, including meeting with Greg Hunt, who was health minister at the time. And they got me in the room with him, and this led to funding being announced for Mackenzie's mission with funding via the MRFF. So the aims of the study were to assess the acceptability and feasibility of an accessible carrier screening program in Australia. And the initial aim was actually to screen about 10,000 couples for carrier status, what wound up being about 1,300 autosomal and X-linked genes before or earlier in pregnancy. It wound up being more like 9,000 couples because of COVID, essentially. We had a whole bunch of GPs ready to start, particularly, and other healthcare professionals ready to start recruitment. And just as we were ready to sort of launch them into recruitment, COVID happened. Anyway, we managed to get around that in various ways and continue with the project. And the outcome measures that we were looking at were uptake, carrier frequency, or really frequency of carrier couples, and the reproductive decisions they made. And we had various streams: psychosocial outcomes, implementation considerations, and health economics. And underpinning it all was bioethics. And we had 2 ethicists who were members of many of our committees and wrote a number of papers along the way about ethics related to carrier screening. There were a couple of MSAC applications that went in sort of sequentially, and I was actually involved in the College of Pathologists application for the 3 genes. And as it happens, it's just last week that was listed on the MBS and testing began. And we put in an application for a Mackenzie-style carrier screening item number, and that didn't result in a recommendation for funding, but MSAC acknowledged that there is an unmet need for funded expanded carrier screening, and also commented that an item number might not be the best way to go about doing that. and invited us to come back again after addressing a number of issues. At the moment, we haven't reapplied. We've got a fully formed and ready to go application, but there are various ongoing discussions about alternate approaches that have been happening. So back to Mackenzie's. The genes, I mentioned about 1,300 genes. The overarching principle that we set for selecting genes for the project was the condition should be one for which the average couple, whoever they might be, would take action to prevent having a child with that condition, or where early diagnosis improves prognosis. An example of that would be something like congenital adrenal insufficiency. There are some genes where babies are born with essentially no cortisol production, and they're fine for a bit and then they keel over and potentially die. And obviously treatment's very straightforward if you know that there's the problem. Or relatively straightforward. I'm not the one doing the treatment, so perhaps I shouldn't be saying that, but compared with a lot of other conditions. So we had a committee that included all the people that you can see on the author list there from the paper. We wrote about that. And we initially had 1,300 genes. During the project, we wound up whittling that down slightly and adding a few genes as well. And we wound up with 1,281. And we removed genes due to technical issues, but also in a couple of instances because evidence emerged that the gene phenotype relationship was not as solid as we had thought when we started. Reporting, so it was a couples-based project, and results were only reported on a couples basis, so only pathogenic or lightly pathogenic variants, and the variant combination. Ideally, we would report if there were a severe presentation, although genotype-phenotype relationships are not always solid, and it's not always possible to be highly confident about that. So there are a lot of debates about reporting certain combinations. Okay, so as I mentioned, a reproductive couple. Importantly, if one partner carried an autosomal variant that was pathogenic and the other partner had a VUS, we did not report that combination. And of course, that means that there are doubtless some false negatives out there, but the cost of reporting VUS is an awful lot of false positives and a great deal of anxiety about what is by definition not an actionable result. So that was considered a preferable approach. And the great majority of couples, as a result, received a low chance result, which didn't mean no chance. And there was a fact sheet that went with the results to make that clear. We didn't provide, apart from X-linked conditions, we didn't provide any individual carrier results. And that was not feasible with a large gene list, partly due to the variant curation demands, but also really importantly, the genetic counselling resourcing. Because if you did individual reporting for a panel of that size, more than 99% of couples, at least one of them would be a carrier for at least one condition. And so you'd essentially be counselling everybody about their positive results, which obviously is not ideal. Recruitment was done through healthcare providers who were educated by the study team, and there were more than 1,000 who signed up, a bit fewer than that who actually recruited any patients. And the initial intent was that GPs would be the majority because we were trying to reflect the way that pre-pregnancy and early pregnancy care is delivered in Australia. And there was a focus on achieving a sample that was as representative of the Australian population as possible. And I'll show just a little bit of the data from that. If I find myself with extra time at the end, I've got some additional slides with more detail. As it happened, because of COVID, we wound up having a rather lower proportion of recruitment through GPs, still more than half. Oh, no, that was still the biggest group, but a lot more from clinical geneticists than we had intended because of the particular motivation for them and for some of the other groups in relation to carrier screening. Enrollment was online. We accidentally COVID-proofed a lot of the project because we had things set up so that the recruiter would provide, initially as a paper copy, but also in an online version, an information sheet that had a unique participant ID and the information about a website to go to, where they received education. They could complete a decision aid, and many of them did and found it helpful, completed surveys and provided consent online. And each partner had to do that separately. Once that was completed and they agreed to screening, and almost everyone who went through the entire process did agree to screening. Not everyone, there are a few who changed their minds at that point. We posted out mouse swab kits and they collected the samples at home and sent them back to us. We had tailored pathways for those who spoke languages other than English. We had a couple of languages that the whole website was translated into, but then we also had approaches for other people using interpreters, and those who are using a known donor to conceive, those with disabilities and with no computer or internet access, although of course that's an increasingly rare group. Results disclosure, the low chance results were uploaded to the study portal, and email went out to the members of the couple saying their results were available, as I said, with a fact sheet explaining that low chance doesn't mean no chance, and a bit more about what had been done and what it meant. Increased chance results were delivered by the study genetic counsellor or the recruiting healthcare practitioner if that was appropriate. So particularly, for example, if there was already a genetics team involved with the family, then they would be the most likely people to be delivering that result. And they're depending, it varied a little bit by state. So in New South Wales, we had very senior genetic counsellors, and a lot of those returns of results didn't necessarily involve me or another clinical geneticist, but a decent number I was involved at some level, or their own clinical geneticist was. Importantly, one of the things the government insisted on was that there should be at least one funded, or as it turned out, one funded cycle of IVF with PGT, because of the concerns about equity issues that might arise. And this was before there were any item numbers for PGT. They came in during the course of the project. And that was actually a really good thing, because it enabled us to study what people would do if cost was not a barrier to PGT. I mentioned ethics, and there were a number of publications that came out of our ethics team. Thought that, well, there is a view that the primary goal of carrier screening is to foster reproductive autonomy by providing information relevant to reproductive decision-making. And so the idea is to design a program that promotes an inclusive attitude towards disability and those living with genetic conditions. Obviously, one of the worries is that if you have a very successful program, there might be increased stigmatization when a child does have if a couple do have a child with a disability. And then as secondary goals, the aim of reducing suffering, promoting health, and improving health equity. And you'll note that one of the papers is entitled Reproductive Carrier Screening, Responding to the Eugenics Critique, which is a critique that's out there. And of course, we don't subscribe to that view, but it was thought important to directly address it. So who did we recruit? Just over 10,000 couples initiated enrolment, but a decent number dropped out. 783 didn't complete enrolment. Just 5 couples completed enrolment, but then decided not to go ahead. 143 couples didn't return kits, and so we wound up with 9,107 couples who completed screening. And there was a mad scramble at the end of the project. We didn't think we were going to get to 9,000, and then we overshot. The estimated uptake was about 46%, and we estimated that by getting recruiters to return their unused forms, and then we could work out how many they'd handed out, and then how many that translated, how many enrolments that translated into. Remembering that this involved a substantial research component, there were all these questionnaires. It took about 30-40 minutes for someone to complete the online process. So there are barriers to participation in Mackenzie's mission that would not apply to a test. And we think that uptake in the real world would be higher than that. For example, non-invasive prenatal screening, which everybody pays for essentially, uptake is over 70%. I think it's up around 80% of couples access that these days in Australia. So we aimed to get a representative sample, and you can see that at least geographically we did pretty well. Each dot is one couple. You can't obviously see all the dots in the cities because they're all on top of each other. There is one dot that we had to remove because there were only 2 people living in the location. So having the dot would identify them. So we had some quite remote couples, and the RFDS got involved, and so there was some recruitment from remote communities through them. This is just one of a number of slides. I may have another one as well, actually, looking at how our cohort compared with the population, and it's compared with people aged 20, women aged 20, no, people aged 24 to 44 years as being the most representative of the cohorts within the Bureau of Statistics data. And you'll see that on the whole, and so that's why the quintiles don't all have 20% in them, because it's because that group are relatively affluent compared with the very old and so on. But you'll see that on the right there, the Mackenzie's mission cohort are generally better off than the population, although we still did have decent numbers in all quintiles. And similarly, a more educated group, and that may be just a factor of the way that the study ran, but it might also be reflective of the fact that those are the people who are likely to access screening. And there is evidence that people who access screening tend to be more educated and information rich, I guess. So one of the challenges for a national program will be how to reach the people that are harder to reach, those with lower socioeconomic groups and with less education, who are going to be more of a challenge. What did we find? So we issued results, as I said, to 9,107 couples, of whom 96% had a low chance result. There were 180, and this reflects the effects of COVID, who already were known to be carriers for at least one condition. And so clearly genetics units and IVF and so on contributed a lot of those. And 151 had a new increased chance where the couple were at population risk, so there wasn't some factor that increased their chance of being carriers, and 24 where there was some factor such as a family history that increased them above population risk. So overall 1.9%, but clearly at population scale you'd expect that to be a bit lower. And there were 4 of the couples that were already known carriers who had a new increased chance result on top of that, and a couple of them were consanguineous couples, but there was at least one that wasn't. And so as an indication of what you might get at population level, those who were recruited by GPs had a significantly lower hit rate of 1.3%. And I suspect that at population scale, you'd be talking somewhere in the 1 to 1.2% range for a panel of this size. Not surprisingly, when you look at consanguineous couples, the pickup rate's much higher, and this 18% is very consistent with numbers from international groups. The Dutch in particular have published a very similar number. So they are clearly a very important group to offer screening to. In the context of the 3-gene item number that's just come out, it's important to note that 80% of the results were not for CF, SMA or Fragile X. So one of the things that we did, and I don't think I put the slides in for this truncated talk, was that we used AGG interrupt testing, which meant that a lot of small Fragile X expansions with a low chance of expanding to full mutation were not reported at all. And so that would have actually depressed the number that we reported. So probably if you were applying that sort of strategy, it's more than 80% are not for CF, SMA or Fragile X. We also reported rare CF variants that wouldn't be included in most of the testing that's happening in relation to the item number. We modelled 2 panels. It's a long story as to why we did this, derived from the Mackenzie's panel, one of about 1,000 genes and one of 400 odd genes, which had yields in our cohort of 1.6 and 1.3%, and found that screening for a large panel of genes is very cost effective, more cost effective than screening for just the 3, which in turn is more cost effective than no screening. One of the quirks of this is that if you look at sort of projected over 5 years, this was notionally starting this year, which obviously didn't happen. The costs largely accrue to the Commonwealth, and the benefits largely accrue to the states, which I don't think was a factor in why MSAC didn't recommend an item number, but may influence government thinking. And clearly some sort of partnership would be desirable between the federal and the state governments. This, I think, is important. it's a good test, but it's far from perfect. So of the known increased chance results that couples came to us with, they already knew about, only about 85% we would have detected and reported. And of those, some of them were technical reasons, such as small copy number variants that we wouldn't have been able to reliably identify, or things like point mutations in SMN1, which you might see on sequencing, but you certainly couldn't be sure you were seeing the right gene. But 17 or 18, in fact, we wouldn't have been able to report just because we wouldn't have been able to classify the variant as likely pathogenic in the absence of an affected individual. So they were variants that have been classified because someone had an affected child, and that is obviously something that we expect to improve over time with better knowledge of the variants that are out there, but it's never going to go away as an issue. What do people do with the information? So one of the interesting things is that 16 out of the 45 couples who were pregnant at the time of results disclosure declined to have prenatal diagnosis. And some of that was because they had results that were at the milder end of the spectrum of conditions that we reported. But there was at least one couple that declined prenatal diagnosis who were at risk for a severe neurological condition, and who I think actually went on to have an affected child. But still, the majority access prenatal diagnosis. The next slide shows this is very complex and busy, but the key figure is those who are not pregnant at the time of result disclosure, 83% had declared an intention to use pre-implantation genetic testing, and there were a number who were still deciding. So that clearly is the overwhelming favourite option when cost is not an option. And it's quite important information. And this essentially documents those outcomes in a different way. So 80% of those not pregnant made a choice to avoid the condition, and 12.5% still deciding. And of those choosing to avoid, the great majority choosing PGT, and most of the rest choosing prenatal diagnosis. And we've had 11 pregnancies so far from the PGT group, and that's actually from a while ago. There'll be more now. So overall, the great majority choose an intervention to avoid having an affected child, but the uptake of prenatal diagnosis is much lower. Did we make people anxious? We did, but not to a really excessive extent. This is the STAI. I'm running out of time, aren't I? Interestingly, those with a known increased chance were just as anxious as those with a new increased chance result. We expect those to head down towards baseline. And decision regret was low. Acceptability was high. 96% thought that the carrier screening should be available to everybody. Only 95% thought it should be available free of charge. We'd like to talk to the 5%. And most were glad to have the information. So in summary, we offered screening to more than 10,000 couples. 9,000 or so wound up having screening. 1.9% had a new increased chance result. And I've talked about MSAC, the fact that we can deliver this via an online platform, and that people use the information to change their reproductive decision making. Where to from here? So the 3 gene carrier screening, I may have seemed to denigrate it, but actually we're only, as far as I know, the second country in the world to have public funding for carrier screening, after Israel, who've had it for quite a long time. So that's a pretty big deal, I think. And it's an important opportunity to see how we go with large-scale screening in the real world in Australia. One of the issues is that only the test was funded, so there hasn't been any support and not a lot of planning really for dealing with all the other considerations around the test, pre-test, laboratory capacity, and post-test issues. Clearly there is more to be done. Okay, so I won't run too bad down.
All right, any questions? Nothing. Oh yeah, go ahead.
Okay, here's this one. Thanks, Edwin. Brilliant talk. I just had a question about the gene selection, and something that I think, especially these days, as we get more and more integrated, I feel like in preconception carrier screening, there's been an absence of cancer genetics people involved in gene selection panels. And I think that's for a variety of reasons, but perhaps a bit of a reluctance to potentially identify something that may have cancer risk implications for the individuals themselves, as well as the potential for the child. Although there are already genes on preconception carrier panels like ATM, FH that could potentially have cancer risk implications in the couples. But for example, constitutional mismatch repair deficiency, we now have growing data of effectiveness of early intervention. But also, if you asked any parents who had a child with CMMRD where their child died a horrible death from an aggressive brain tumor, for example, they would say, I would have wanted this tested on a preconception carrier screening panel. How do you think in future we can have a more collaborative relationship in these gene selection panels?
So look, I can tell you how we thought about this issue. We knew that we were going to be doing consent online, and we didn't think that we could adequately consent. So the gene that we thought about this for the most was BRCA2 because of Fanconi. Clearly it met all our criteria for inclusion. But we didn't think that we were adequately consenting people to be giving them that information. And we couldn't see a way of dealing with that. And so we dealt with it by excluding the gene. Now, is that the right decision? I don't know. It's the decision we made. We still did leave in genes which, as you say, have got potential risks. And it's not only that. I mean, like you think about X-linked or port, women with X-linked or port variants can have quite significant problems, and even with Fragile X, there are implications in many of the X-linked genes. So it's a challenge, and I think, well, you have made the case for inclusion of such genes. I think you can. I do think that you have to think very hard about how you're delivering the test and how you're going to handle that information pre-test and post-test. So I'm sorry if that feels like I'm ducking the question a bit.
Not.
But,
I mean, the biggest challenge with CMMRD is PMS2 is the most common contributor to CMMRD, and there's technical difficulties with exome sequencing.
Yeah, so the inversions we wouldn't pick up.
I do have another question if we have time. Sorry, unless anyone else does. No. So I guess my question is just around workforce and delivering this type of program. And, I guess as we're seeing more and more genetic testing programs popping up, I was curious about what you said about the delivery of the high or the increased chance result.
Yep.
And referring to, it being mainly only senior genetic counsellors and whatnot. Whereas in my mind, I would have thought delivering that type of result, reproductive carrier screening, is very much within the job description of a genetic counsellor. And how do you think that ties into, the reluctance to try and get some sort of genetic counselling Medicare item number across the board? Getting the Medicare item numbers for these screening programs is all well and good, but if we don't have the accompanying item numbers and things like that to support the rollout in terms of the workforce resources, what do you think we as genomics research programs can do to really advocate for that, to get that across the line?
Okay, so just the first part first. I guess, so I was a bit surprised when I found the other states were involving a geneticist in all of those initial meetings. Because I agree with you. I think it's within the scope. And I guess the fact that I emphasised that we had senior genetic counsellors. Kirsten Boggs is one of our genetic counsellors, and she's less senior than the other two, but still very experienced in this kind of stuff. I'm not sure I would ask someone straight out of uni to be kind of phoning up a couple they've never met and giving them confronting information. It might be a bit hard. In terms of advocating, there's been a lot of, the HGSA has done a lot of advocating on this issue, and unfortunately it hasn't gone as well as we'd like. I guess we have to keep trying. I mean, I think the answer is probably via our professional organisations, because it's not the sort of thing where an individual right to government generally has a lot of impact. Yeah, so I would say work within your professional organisations is probably the best bet.
Just in terms of the education, what I've found really interesting, I mean, I'm smack bang in this age of, you know, this type of thing. So I've had lots of conversations with peers, friends, etc. And I feel like there's a massive misunderstanding, particularly with this new Medicare item number, because everyone refers to it as the three big ones or the three main ones. And they just don't understand that it's not that these three conditions are any more severe than any of the other conditions included. It's just purely that they tend to be more common.
I mean, when you think about it, it's pretty impressive that by doing 3 genes, you get 20% as much hit rate as you do if you do 1,300 genes. So, you know, I mean, in that sense, they are the 3 big ones. Look, people have NIPS and they think they've covered all genetic conditions. I guess I'm all in favour of improving genetic literacy, and hopefully once screening's been around for a bit longer, people will get the idea a bit more. But I mean, I think it's easy for us to sit thinking about genetics and assume that other people are going to take all this stuff on board, and it's probably not realistic, really.
Great. That's great questions and great answers. Just wanted to check if anyone has a question for Dr. Fuentes, because we didn't have a lot of questions earlier. A lot of time for questions. All right. Well, thanks again to all of our speakers. And thanks to Samantha for organizing these talks. Awesome.
Yeah.
Thanks for that.
Yeah.
So to see those results. Looking forward to the paper that's under review.
No, it's been reviewed. Now we're revising it.
Thank you, Amy.
Yes.
All right.
Yeah, all right.
Awesome. Thanks, Edwin.
No worries.